Talk on IFIS management of cataracts. Now let me invite Dr. Reshmi, a young surgeon, and she will talk to us on challenges faced by a beginner. Dr. Reshmi.
Good morning, all of you. First of all, I'd like to thank Jason sir and JP sir for giving me this opportunity. Here I will be talking about challenges in phaco for beginners. There are numerous challenges faced by a beginning phaco surgeon, especially if you are the only operating surgeon in the hospital. So, I would like to explain few challenges that I think will be beneficial for the beginner surgeons. So, I divided it into three parts: preoperative, intraoperative, and postoperative ones. The preoperative hurdles, the most important one is the patient selection. You should always have a good rapport with your patient. Explain if they have any risk factors. Do proper blood investigations and get a physician fitness. Always check the A scan report prior to surgery because you can have an assessment of the anterior chamber depth, axial length, IOL power, etc. and you can anticipate any issues. When you select patients, in the initial cases, it is better to exclude small sunken eyes, small pupil, shallow AC, extremely soft and hard cataract, those deaf and uncooperative patients, PPC, mature cataract, and highly demanding patients. You should have a good knowledge of your machines. The microscope should have good retroillumination, proper focusing, magnification, centration, and you should be aware of the foot pedal control. Phaco parameters and the foot switch controls should be familiar. Apart from this, we also need good instruments, anesthesia, and supporting staff. Coming to the intraoperative challenges, patient positioning is very important. Positioning of the head, chin, and the pupil should be considered. It is better to tilt the head slightly to the side because it prevents pooling of the fluid in the conjunctival sac. Slightly lift the chin so the dye comes in level with the microscope light. In order to avoid Bell's phenomenon, ask the patient to look directly into the microscope light and open both eyes simultaneously. It is better to keep the microscope axis at 15-degree oblique manner, the surgeon's head and neck in the primary position, and the patient's visual axis in the primary position. This will enhance red reflex. Also, drape the lashes properly. Never keep the speculum too much widened and it can result in difficult instrumentation and increased posterior pressure. In the initial cases, select a peribulbar or subtenon, whichever the surgeon is comfortable, and later can update to intracameral and topical anesthesia. Coming to the incision creation, I prefer a triplanar incision which include a small vertical groove, a 2 mm intracorneal tunnel, and then entry into the anterior chamber which is always parallel to the iris. Never dimple into the cornea as it can result in a chevron shaped incision and can result in a poor sealing technique. And also the intracorneal tunnel should not be more than 2 mm because it can result in difficult instrumentation, and if it's less than 2 mm it can produce iris prolapse also. The side port is made with a 15-degree blade. Never make it too anterior because it can result in difficult instrumentation. So be careful that the blade is not rotating when you are introducing it. Always keep it at least 2 to 3 clock hours away from the main port for easy handling. Coming to the capsular axis, try to get a 5 to 6 mm capsular axis. Never keep the capsule floating inside the anterior chamber. Always keep it flat with proper viscoelastic. Hold the eye with the left hand. Always end from an outside in manner. If it is a smaller axis, and try to enlarge it as a part of second axis. Suppose you have a runaway axis. Don't panic. Put adequate viscoelastic and keep the capsule flat and unfold. Use a microaxis forceps through the side port. Identify the root of the tear. Hold it and in a swift motion push it towards the center and complete the axis. This is the Little's technique. Coming to the hydro procedure, always remove excess viscoelastic in the anterior chamber prior to hydro dissection and thus decompress the anterior chamber. Fluid is injected just beneath the anterior lens capsule towards the equator. See the fluid wave. Always tap at the nucleus and remove the excess fluid before repeating the next hydro. Multi-quadrant hydro dissection is the one better. Inject fluid into the nucleus matter. See the golden ring, and that is the hydrodelineation. Once the nucleus rotation is complete, you can start your phacoemulsification. Go with a bevel down pattern to make the trench. give maximum power at the center of the nucleus because it is a biconvex in shape. The width of the tunnel should be around 1.5 times the phaco tip and the depth around 2.5 times the phaco tip, or you can always check for the red reflex also. Rotate the nucleus and complete the trenching. Keep the instruments at maximum depth of the trench and then only separate. Always ensure complete separation of the posterior plate. This is very important. Suppose if you have a soft cataract, there is always a chance of cheese wearing of the nucleus. So here you can go for two options. Either you can hydroprolapse the nucleus through a 5 mm access and then aspirate it, or in a stop and shop method you can make a deep trench, separate it properly and then aspirate. Coming to the irrigation aspiration, I personally like the bimanual irrigation aspiration better. Always hold the anterior lamina of the cortex and pull it tangentially towards the center to avoid less stress on the sonules. Proceed in a clockwise or anti-clockwise manner, whichever is comfortable, because it is easy to remove the cortex from the adjacent area where it is already removed. When you load the IOL, always make sure that the edges of the optics is tucked under the groove. The haptics are properly folded. And you can always see it from outside whether it is properly folded. And when loading the IOL also, in the injector also, just withdraw and see whether the trailing haptic is entrapped within the plunger. While inserting, always use the dialer as a second instrument to assist because there is a chance of IOL flip. The leading haptic should go into the bag and gently dial the trailing haptic. The wound closure, always start at 50% of the stromal depth. Never inject too forcefully because it can result in DM detachment. If there is a small DM detachment you notice at the end of the surgery, it's always better to put a small air bubble in the anterior chamber so that it will be sealed properly. So the important points to remember is that ensure the cannula patency before injecting anything into the anterior chamber. Always check the irrigation flowing in between. Do only if you can see properly. Be familiar with SICS or ECCE. Know the technique of anterior vitrectomy, 3-piece IOL and iris glow lens if needed. In the postoperative period, always see your post-op patients. Counsel for the other eye if they are happy patients, and refer, in case you want to refer to your patient to somebody else, refer only to a consultant whom you can always trust. So the final tips are: believe in yourself, always observe and learn, don't hesitate to ask for help, convert if needed, and critically analyze your errors. Thank you for the kind listening.